Hello and welcome to the first Anticoag Forum webinar of 2026. And we are super excited to kick this off with an exciting topic, which is the use of DOAC-sensitive testing, emerging evidence, practical applications, and what's next. And we have a great lineup of speakers here who will talk about lessons that we've learned from point of care warfarin testing, and now some of the emerging use of anti-10A and other DOAC-sensitive technologies. First, I'm going to make a few announcements about the Anticoag Forum. Next. First, a heads up that we have a new premium content called the Hubs and Spokes, and you can go to the Anticoag Forum website and take a look at these. This is great for people who are just starting to learn about anticoagulants. There's a lot of foundational topics in common areas like antithrombotic pharmacology, atrial fibrillation, valvular disease. And then with each of these 5 hubs, you get access to a set of spokes, which are more advanced and dynamic content, such as links to webinars and podcasts. So go ahead, check it out on our website and go ahead and register. Next slide. Here is another resource that I wanted to make everyone aware of. If you missed the 2025 live virtual boot camp that was held in October, and if you missed that and want to see the content that was presented, register for the on-demand boot camp, which is a great way to get introduced to anticoagulation and antithrombotic management, or serve as a refresher course with really awesome talks from 16 of our great speakers. So check out our website to see how you can register for this recorded on-demand boot camp. Next slide. I know it's barely a week into 2026, but I want to give you a heads up for the 2027 19th National Conference from the Anticoag Forum. This is one of the favorite conferences for anticoagulation providers, a way to come in person and learn from experts about topics in antithrombotic therapy, and it will be held in Orlando, Florida, in 2027 in April at the Hilton Orlando Lake Buena Vista. Registration is going to open up in 2026, so just keep your eyes open. And then finally, one more conference to make you all aware of, the THSNA conference. So Anticoag Forum is going to be at the THSNA Summit in March, and this will be held in Portland, Oregon. Hopefully we'll see you there. And if you are part of Anticoag Forum and you are registering for THSNA, just show your Anticoag Forum spirit and say you're affiliated when you register. Those are our major announcements. So I'll have you advance one more slide, and I will introduce the presenters and panelists for today's webinar. So I'm Margaret Fang, and I am a hospital-based physician at UCSF, and I'm also the medical director of our UCSF Anticoagulation Clinic. I am delighted to be joined by the great Arthur Allen, who is the Anticoag Program Manager at the VA Salt Lake City Healthcare System, and we will moderate today's session. We're delighted to have as our main presenter, Libby Ronchetto, who is an internal medicine resident at Henry Ford Hospital in Detroit, and with guest panelists, Dr. Jean Connors, who's at the Dana-Farber Cancer Institute, the medical director of the Anticoagulation Management Service and a professor of medicine at Harvard Medical School, and Dr. Kamran Hajiyev, who is an interventional neuroradiologist at the Klinikum Stuttgart. So Dr. Ronchetto, I'm delighted to turn over the screen to you and have a lot to learn about DOAC-sensitive testing.
Yeah, well, thank you so much, Margaret, for the introduction. Like Margaret said, my name's Libby. I'm a third-year internal medicine resident at Henry Ford Hospital. I first became kind of involved or interested in this project while I was rounding with Dr. Scott Cates, who I'm sure many of you know. He proposed this project, including both this webinar and then a manuscript that we're currently working on to our residency class. And that's how I found my way into this work, and I'm excited to share it with you all today. Before we dive in, I just want to briefly outline a few objectives for the talk today. So first, We'll review how anticoagulation monitoring has kind of evolved in the context of warfarin, focusing primarily on the development of point-of-care INR testing. Next, we'll shift gears to focus on direct oral anticoagulants, or DOACs, and review current approaches to assessing anticoagulant effect, so particularly through 10A monitoring. And then we'll get into newer DOAC-sensitive technologies. And then finally, we'll discuss where these tests may fit clinically. So to set the stage, it's helpful to review and revisit warfarin because it defines a lot about how we think about anticoagulation monitoring. And we'll highlight some of the difference here about how we're going to get into with DOACs is a bit different. So warfarin, we know it has a narrow therapeutic index. There's widely variable dosing requirements between individuals, necessitating frequent monitoring. It's essential to ensure efficacy, meaning prevention of thrombosis, but also minimizing adverse outcomes as observational data has certainly shown increased risks of thromboembolism when INR monitoring is suboptimal, reinforcing this need for monitoring. More notably, from a how perspective, though, early warfarin monitoring relied on prothrombin time, so PT, which then changed to INR in about the 1980s. And INR really standardized PT measurement across laboratories, notably across thromboplastin reagents, enabling safer and more consistent warfarin prescribing. But this standardization also importantly enabled the development of point-of-care testing. Traditionally, INR testing was performed in lab with venous blood, so obtained via venipuncture. So a key concern early on when this point-of-care INR monitoring idea was proposed was whether capillary blood, so obtained via fingerstick, would provide reliable INR results when compared with venous samples. Many studies have looked at this question, tried to answer this question. Notably, one large meta-analysis concluded that precision of point-of-care monitoring, so the capillary finger stick that's monitored in a point-of-care device, is generally acceptable for clinical use. I included here on the right of your screen results from a 2002 study where you have INR capillary blood along the x-axis and then INR measured via venous blood on the y-axis, measured from the same point-of-care device, and you can clearly see the linear correlation. These differences between capillary and INR or venous INRs were actually statistically significantly different, but the mean relative deviation was only about 2 to 6%, which is well within the clinically accepted limits of INR variation. So in the late 1990s, early 2000s, we saw point-of-care INR monitoring begin to expand. Several devices entered the market, notably including the Roche Diagnostic CoaguCheck series, which is shown here on the bottom right. It looks like the picture kind of widened, at least on my screen, but that's a very common device used across the US and even internationally. I also included this iStat Abbott device here, which is a very common point-of-care test used in office, so patients don't need to go to a lab for this test. And the availability of these devices really enabled two related but distinct care models. So self-testing and self-management. In self-testing care models, patients measure their INR at home and report the results to a healthcare provider who then provide dosing instructions. This is more similar to your clinic-based point-of-care INR monitoring as well, so this Abbott device that I mentioned, where a patient essentially doesn't need to go to a lab for a venous stick. They can do a point of care in-lab monitoring, and then a clinician can adjust warfarin dosing based on that. Compared to the self-management model, where patients are going to both test their INR and adjust their warfarin dose themselves at home. They're following, in this case, a predefined and pretty carefully taught algorithm. There's actually been growing interest in expanding the patient self-management care model, including there's an ongoing clinical trial led by Dan Witt and colleagues aimed at improving the safety of ambulatory warfarin care through increasing this patient or self-management model. Point of care INR testing advantages are certainly pretty substantial, and they overlap quite a bit between the self-testing and the self-management care models. Benefits include improved accessibility, reduced travel and time burdens, and in many cases, lower overall costs. Importantly, studies have shown both self-testing and self-management are associated with comparable, or in some cases, even improved time and therapeutic range, so meeting your INR goals, compared with standard clinic-based monitoring. And then perhaps beyond laboratory metrics, and perhaps more importantly, your your patient-centered outcomes are certainly going to matter. And studies consistently show higher patient satisfaction with point of care INR testing, even when that testing occurs in an office-based setting, because it's preventing that extra lab step. That being said, point of care INR testing isn't without limitations. You're going to occasionally need to confirm a point of care INR with a clinic or with a laboratory-based INR, especially in the settings of like unexpected results or inconsistent findings. And then successful implementation of both these self-testing and the self-management models require the right patient. Certainly more so in self-management, but even in self-testing, there's some element of patient education and instruction that is required, and then ongoing clinical support when questions arise. I bring all of this up kind of to highlight the differences of how we're going to talk about DOAC monitoring compared to the point of care INR monitoring that we just discussed. So we'll now transition a bit into direct oral anticoagulants or DOACs. We know they're now first-line therapy for many clinical scenarios, most requiring long-term anticoagulation, so your AFib, your venous thromboembolism. As compared with warfarin, they offer similar to improved efficacy, improved safety profile, and perhaps most notably from a patient perspective, one of the most notable benefits is the advantage of lack of routine monitoring. You don't need to get these frequent lab draws. Because of their predictable pharmacodynamics and shorter half-lives, DOACs are administered at fixed doses with few exceptions, and require pretty limited dietary drug interaction considerations. However, as DOAC use has increased and is expected to continue to do so, attention is turning and has turned towards whether and when measuring, monitoring knowledge of DOAC anticoagulant effect might be helpful in specific clinical scenarios. But before we discuss those scenarios, it's important to understand how DOAC activity can be assessed. Your standard laboratory coagulation test, so your PT and your PTT, and even viscoelastic testing is not going to reliably or quantitatively reflect DOAC activity. So regarding your PT and your PTT, these assays may provide limited indirect pharmacodynamic information, but they're not going to correlate with DOAC concentration or necessarily effect. These values are also often impacted by other factors, especially in critically ill patients, so liver disease, DIC, coagulation factor deficiencies. In the absence of all of these co-founding factors, abnormal values may point towards DOAC exposure as a qualitative measure, but they can't quantify levels. And it's really important to note that even patients with therapeutic concentrations of DOACs, apixaban, rivaroxaban may have normal and have shown to have normal PT and PTT results. So they're not even reliable in the sense of qualitatively ruling out DOAC exposure. Additionally, many studies have looked at DOAC impact on clotting time or reaction time in your viscoelastic testing, and evidence is really mixed. Prolonged R-time, clotting time has been observed, but other studies have shown that viscoelastic testing is not reliably abnormal despite recent DOAC administration or relevant DOAC plasma concentrations, which really suggests limited sensitivity of these basic anticoagulant tests to monitor DOAC concentration or their anticoagulant effect. At the other end of this spectrum, you have liquid chromatography with tandem mass spectrometry, which is your gold standard for measuring DOAC plasma concentration. It provides highly specific and sensitive pharmacokinetic data, but its clinical utility is incredibly limited. There's cost, lack of availability, prolonged turnaround times, and expert laboratory methods that make it just impractical to use in a clinical setting. Which brings me to anti-10A testing, which is an approach that's utilized to assess DOAC anticoagulant effect. So anti-10A assays are plasma-based, chromogenic assays that quantify factor 10A inhibition. So in brief, a known amount of factor 10A is added to the patient plasma to be tested, and then the degree to which factor 10A is inhibited is going to be quantified by release of a chromogenic substrate, i.e. less color generation is going to correspond with greater 10A inhibition and vice versa. Traditionally, these assays have been calibrated to heparin, so either unfractionated heparin or low molecular weight heparin, and results are going to be reported in international units per milliliter. These assays are increasingly being used in the management of heparin therapy as availability and turnaround time improves. But it's important to note that any anticoagulant that inhibits factor 10A, so your DOACs, are going to influence this anti-10A activity and thus the result of your anti-10A testing. So if a heparin calibrated anti-10A assay is used in a patient taking a DOAC, the result is going to reflect the presence of 10A inhibition and not a drug concentration of DOAC. This distinction is really important, especially as we start to talk about how these tests could possibly be used in a clinical scenario. Conversely, if an anti-10A assay value of 0 were to be reported, which is what would be expected in a patient that has no anti-10A on board, so no heparin, no DOACs, that value might be of clinical relevance because you know in that case there's no anti-10A inhibition from any drugs on board. Lastly, it's important to highlight just your general limitations of chromogenic assays. So because anti-10A testing is chromogenic, factors that alter plasma clarity or color, so think hypertriglyceridemia or severe hyperbilirubinemia, can interfere with these results quite a bit. Assays are improving, but it's still a notable limitation to keep in mind. Which brings me to DOAC-sensitive anti-10A assays. This builds on the concept of anti-10A testing, but these are calibrated to specific drugs, specific DOACs. So these are also plasma-based chromogenic assays, but they're calibrated to an individual DOAC rather than heparin. This allows for quantitative measurement of specific anticoagulant that it's calibrated for. Typically, these are going to be reported in nanograms per milliliter. And this form of testing is generally accepted as an alternative to that gold standard liquid chromatography that we talked about for measuring DOAC concentration. There's one currently FDA-approved test for apixaban. And so in this system, apixaban, if it were present in a patient's plasma, would neutralize the factor 10A that is added to perform the test. The remaining 10A is then quantified through release of a colored product. So more color corresponds to less drug, vice versa. And then your results are reported calibrated to a DOAC concentration. So you're going to get a nanograms per milliliter result specific to a DOAC. These assays do represent a significant technical advance, but their interpretation is what remains very challenging. So therapeutic ranges for DOAC concentrations have not been established. We have on-therapy peak and trough concentrations that have been described, and these values are primarily derived from pharmacokinetic modeling from the phase 2 and 3 clinical trials, or from small cohorts of healthy volunteers. But to date, there are no large prospective studies that have established a clear correlation between DOAC concentration, so your measured DOAC via DOAC-sensitive anti-10A testing, and clinical outcomes, most notably thrombosis or bleeding. As a result, optimal cutoffs for clinical decision-making are not outcome validated. They're mostly derived from expert or consensus opinion. That being said, we've heard of the 30 and the 50 nanograms per milliliter thresholds quite a bit. But like I said, these aren't outcome validated. They're largely based on consensus opinions. The 30 and the 50 have both been used for thresholds to indicate minimal to negligible anticoagulant effect, so less than 30 or less than 50. Greater than 50 has been described as meaningful anticoagulant effect. And then values greater than 200 or 300 nanograms per milliliter are, in some cases, described as higher than expected, but they can still be seen in recent dosing of a DOAC, kind of leaving a question mark for the upper end. And then there's also real-world data that highlights additional challenges, notably interpatient variability and then inter-assay variability as well in DOAC concentrations. So interpatient variability is pretty substantial, and it's more relevant at trough levels of DOACs. There was a multi-center study in 2016 that looked at interpatient variability in over 300 patients taking a range of DOACs. And this study included patients on apixaban, rivaroxaban, and dabigatran. I won't get into the different coefficients of variation for each medication, but overall, the mean coefficient of variation at peak was 46%, and at trough was as high as 63. The mean was 63, as high as 68% for specific drugs. So pretty significant interpatient variability there. There's also interassay variation, which complicates interpretation of these concentrations. Assays do generally correlate pretty well, but variability becomes more clinically relevant at your lower drug concentrations. There was a study published in 2025 that looked at this interassay variability between three commonly used assays. So it looked at 129 different samples, and it measured them using three different DOAC-specific anti-10A assays. 10 out of these 129 samples crossed the 30 nanogram per milliliter threshold, meaning across three different assays, you had different results above or below the 30 nanogram per milliliter threshold. Of note, none of these crossed the important 50, so none of those 10 that crossed the 30 threshold crossed the 50 nanogram per milliliter threshold. But you can see how this might be clinically relevant if we're starting to use these thresholds. And then lastly, and perhaps most importantly, these assays are limited by availability and turnaround time, which is an important consideration if we're going to discuss their use in clinical practice. So these questions and limitations that I've mentioned have largely driven interest and promoted the development into newer approaches, a few of which I'm going to get into here. The first of which is the DOASense DOAC dipstick, which is shown here. This is a urine-based test. It contains 4 pads that you can see there on the right. There's 2 control pads. One is your urine color and one is your creatinine pad. So the urine color pad is going to control for abnormal urine color that may alter results, and then the creatinine pad is going to control for impaired renal function, which may alter results, obviously. And then you have 2 analytical pads to determine the presence of drug. So this is going to give a positive or a negative result based on a predefined urinary threshold. Studies have showed pretty high sensitivity and specificity, most notably high negative predictive value as well for detecting plasma concentration of DOAC less than 30 nanograms per milliliter, that threshold cited that we talked about. Next, I'll get into a coagulometer method. So this is the Parasphere Technologies point of care coagulometer, which is another emerging technology in this field. So this device uses whole blood, just 10 to 15 microliters, and requires no reagents. So it's going to be that same finger poke method that we talked about with the warfarin point of care INRs. And this method mirrors the historical manual whole blood clotting time. So the device uses an algorithm identified as a point where fibrin formation peaks and then provides a clotting time within minutes. You can see here on the right, the drugs and the words are less important, and I'll point you towards the linearity in a moment, but you have 4 different drugs, so rivaroxaban, apixaban, edoxaban, and dabigatran. Along your x-axis, you have drug concentration, and along your y-axis, you have the point of care clotting time. And you can see the linearity between drug concentration and clotting time pretty significantly throughout all 4 drugs. Early studies showed using healthy whole blood spiked with varying DOAC concentrations. So these aren't patients taking DOACs. This is blood a patient doesn't take a DOAC that is then spiked with varying known DOAC concentrations. You can see the strong linear correlation between the clotting time from the point of care device and drug concentration. And of note, these tests showed even high sensitivities at the lower levels of DOAC concentrations. Unlike the urine-based testing, this approach does provide more pharmacodynamic information and reflects your current anticoagulant activity independent of renal excretion or the time the urine was formed. It is important to note that this test isn't going to distinguish the cause of impaired coagulation, so results may be abnormal in patients with acquired or congenital coagulopathies as well. And that's something important to keep in mind as we discuss this next technology as well. So this is the iLine microDOAC. It's a platform that similarly uses whole blood and a clotting time assay to assess anticoagulant effect. But data is currently limited. Publications are pending for this device. It does represent another example, though, of efforts to bring DOAC testing more towards point of care. These technologies and previously described testing modalities raise the question of when or how or even why might DOAC testing actually matter. So I wanted to discuss a few potential clinical applications, and I'm sure we'll get into this a bit in the Q&A as well. One major area to discuss is stroke care. So despite DOAC therapy, we know that patients remain at risk for ischemic stroke. Current AHA and ASA guidelines do advise against the risk or against the use of IV thrombolytics in patients who have taken a DOACs in the preceding 48 hours, unless appropriate coagulation testing is normal. And in practice, you can see how DOAC exposure at the time of presenting for an acute stroke might be a question mark, whether related to new cognitive deficits from the stroke, baseline cognitive deficits, incomplete medication history, or patients not being with the person that manages their medication. So in these situations, rapid assessment of anticoagulant effect when DOAC use is suspected but can't be confirmed may help inform your management decisions. There's also ongoing clinical trials in Germany and then an observational study out of Australia assessing the use of urine-based testing that I previously had discussed in stroke care, but results that those studies are still pending, so results are certainly a ways away. Another area that there's potential for use of DOAC testing is in major bleeding. So bleeding remains the most common complication associated with DOAC use and contributes to many emergency room visits each year. Clinical trial data show rates of major bleeding anywhere from 2 to 3.5% per year in your DOAC-treated groups. And reversal strategies are not without risk. So now primarily the use of prothrombin complex concentrate or PCC can be considered in settings of major bleeding, but these therapies carry risk. So most notably thromboembolism, but their cost and time for administration also bring in another layer of complexity to management decisions. So assessment of DOAC effect may be useful to help guide whether therapy's reversal is warranted or if it should be taken off the table if DOAC concentrations aren't contributing to the major bleed. And then lastly, perioperative management is another potential clinical application that I wanted to discuss. In emergent or urgent procedures, DOAC exposure may be unknown, whether due to severity of illness or injuries. DOAC exposure may also not matter on your way to the OR if it is absolutely a necessary surgery or intervention. That being said, if there's a bit of time, knowing whether DOACs are on board in settings where it is unknown might be useful. But even when reversal is not being considered preoperatively because of the need for emergent intervention, knowledge of DOAC effect might still be useful if bleeding were to become an issue intraoperatively or even postoperatively. And then lastly, routine or elective intervention settings, there may be a role for DOAC monitoring here as well. We have guidelines based on when to stop DOACs prior to a procedure. But as we know, there's patients that arrive that might not be the most reliable historian in terms of when they stopped their DOAC. And in this case, assessment of DOAC anticoagulant effect might be useful. So I've talked about quite a bit about the different ways of testing DOACs, also these potential clinical applications. One of the major benefits of DOACs is that they don't require routine monitoring, and that's something that patients really like about these drugs. There still may be certain situations where knowledge of anticoagulant effect from a DOAC may guide management. And traditional tests, anticoagulant tests, aren't going to give us the full picture, but these emerging DOAC-sensitive assays and point-of-care tools might provide faster, more actionable data for us to go off of. The key going forward will be figuring out if and how these tools can be thoughtfully used in practice. I will stop there. Thank you so much for listening, and I will turn it over to our panel and moderators.
Thank you, Libby, for a very comprehensive and interesting discussion about, again, the history of warfarin point of care testing and how we're now seeing if this is useful in DOAC care. And there's a lot of questions that were submitted by the registrants in advance, as well as I'm seeing in the Q&A about this, and we will start discussing it. Is it reasonable to apply our model to warfarin to DOACs? But maybe we'll start first with one of our guest panelists, Dr. Hajiyev, who actually has practical experience in using DOAC point of care testing. So would love to hear some just what is it like in clinical care? How do you use it?
Thank you, Margaret. I would say we are in Germany. This is one of the biggest neurovascular center. We are doing more than 2,000 procedures per year, and then including more than 500 stroke thrombectomy cases. The first, we have lots of the patients under antiaggregation, but as well as anticoagulation. So first, we have in our angio suite 3 different devices to test the antiaggregation effect. What we know, and in European population, for example, clopidogrel resistance is up to 55%. So we have started just again the questions about what about anticoagulation? Is it correct? Is fix those concepts? So you give anticoagulation, and is the patient anticoagulated? So we got this perosphere clot check device at just almost 1 year. The first we decided just to test our patients getting the anticoagulation. But what we have seen first is the same drug, same concentration, is more or less the same, the patient and the same weight. This totally inter-individual variability. So the one patient had, for example, under 2 times 150 milligram dabigatran, minor bleeding even. Another patient had nothing at all. So we tested the both patients. We have seen if the one patient was really showed the hyper response in the clot check results, showing that it's basically functional coagulation status, saying that in the results is really simple results, and showing that if the patient had the hyper response or normal response or no response at all. So we have seen this inter-individual the response, the variability of the drugs, the same drug. So we had just I made some clinical scenarios, for example, in collaboration with our neurologist. As I said, we're doing more than 500 thrombectomy cases per year. So we started just asking questions. For example, the patients under DOAC, is significant proportion of the patients under DOAC for atrial fibrillation, they are having also race strokes. Why is that? So we have started the patient, they're coming to us for stroke thrombectomy with the proved large vessel occlusion. We tested the patient. We have seen that regarding the clot check, the results, they are non-responders, showing that in prothrombotic status. So obviously, we know that stroke patients, the building clot burden, they are prothrombotic status. So they are under DOAC. We could actually show that with clot check, they are not anticoagulated. So we correlated this with anti-10A results. What's really interesting is some patients had really 10A inhibition, but the not anticoagulated results in the clot check. Just starting, why is that? It's really interesting. So basically, what we are thinking is because it opens the way for IV thrombolysis. Not every patient coming directly to the primary stroke center. We all know what is IV thrombolysis, what benefit is IV thrombolysis could achieve. And most of the times, patients don't get the IV thrombolysis because of the DOAC. So if you could, let's say, show if the patients under DOAC having stroke had a clot burden, they are not anticoagulated. Basically, you can give the TPA and thrombolysis, and it's let's say this is what we want to do. The first testing this patient and this for a safety endpoint and giving TPA, because what we experienced in this period of time, like more or less 10 or 11 months, these stroke patients, they are not anticoagulated under DOAC, or vice versa, another patients, for example, chronic subdural hematomas, elderly patients under DOAC for different reasons, they're getting the subdural hematomas for just spontaneously. And we tested some patients also in the clot check here with us, and we have seen they have a hyper response for that. So basically, in our field in neuroendovascular surgery, is the MMA embolization is now high. We can treat also in the minimal invasive method this subdural hematomas. The question is why these patients without trauma getting subdural hematomas? The question is the DOAC are they hyper responder for DOAC? So this quantitative results giving us, for example, also the adjusted dosage. We're giving the patients, if we see there is hyper response regarding the clot check results, we can go a bit, let's say, reduce the dosage and then test again. What we see is that correlates with the medication. And the patient's the coagulation status now is normal anticoagulation level. So it's really interesting, and like we're exploring the patients and also the indication, and now we are building some protocols to including the patients and doing some prospective research and then studies about that. Yeah.
Thanks for walking us through your experience. And maybe I'm going to
Thank you.
simplify this a little bit. And from what Libby was describing about testing for DOACs, first, it seems like it boils down into like one set of indications, which is we don't know if this person has been taking a DOAC or not, and we want some way of figuring out if they have active anticoagulant effect. And so then having a point of care assay might be useful, or if you had a really fast anti-10A assay, you can measure the degree. So that's one category that might be helpful for, say, can you give thrombolysis to someone, or do you need to provide a reversal agent if there's someone's bleeding? And then what I'm hearing, Kamran, you say what you're exploring is this idea that at least for something like intravenous heparin or warfarin, where you're aiming for this therapeutic range, and if someone's having a stroke and you test their anticoagulant, maybe they actually are subtherapeutic, or maybe if they're bleeding, they're super therapeutic. And there's really good evidence, outcome data supporting that for like warfarin, but I don't know of firm links between DOAC concentration and clinical outcomes that can help us guide, we should aim for this range. So we have experts here, Dr. Connors, Arthur. Do you want to comment on, do we have a therapeutic range for DOACs?
I'll defer that to Jean. I have some thoughts on this, but I was going to I have a question for Jean. But Jean, if you answer that first, then I'll try to bring it home with some a different, like a stepwise approach if we could. But yeah, go ahead.
Okay, yeah, no, I think this is a key message that we need to get across. And Libby, I think you did a great job touching on this in your presentation. The DOAC trials did a lot of preclinical and early clinical phase 1 PK/PD studies and really did look for a one size fits almost all dosing. And so when the phase 3 trials were designed, they were with fixed doses for people, in a certain range of weights and age and creatinine and all of that to get into the phase 3 RCT. The data we have about levels are post hoc, post study, right? So they were drawn while people were in these phase 3 trials, or as Libby said, even earlier, phase 1, phase 2, and were only analyzed after. And so if you look at these levels, for example, like if you look at the data, let's just pick apixaban, for the phase 3 VTE trial and rivaroxaban, the average age of patients in that trial was 57. So then if you look at the data for the levels in people in the stroke prevention with AF, the average age was like 75. So that influences the levels. And when you look at the peak and the troughs, you will see they actually overlap. So that's a long way of saying the levels right now in the data that we have, the efficacy was not done based on levels. The efficacy from the trials came on the fixed dose and how people did in compared to warfarin. So we don't have a target range to aim for in these when we measure DOAC levels, right? We might have a little bit of a sense, but you can have someone who has a peak level that is the same as someone's trough level, and none of us would recommend changing their dose based on those levels.
Right. Yeah. So thanks, Jean, for that. So this is very interesting stuff, and there's a lot of this kind of emerging things. But I think we have to be very careful with the message here. And so, like me, Jean lived this history. We had warfarin. We begged and pleaded and cried to have drugs that didn't require monitoring. And then as soon as we got them, what did we do? We cried that we couldn't monitor them. Right. I mean, and so I think we have to be careful. If I look at the Q&A that are coming in, there's a lot of questions across the range of where this testing should be used, and some that imply, oh, we should just make sure that everybody on a DOAC is on the right dose. So let's walk through this, Jean. Very practically, some folks have access to a heparin anti-10A at their facility, and any other 10A, even an LMWH 10A, is a send-off test. Some sites can do a send-off test for an anti-10A for apixaban calibrated, but it takes a week. Some sites can do these on site, get a result in an hour, right? And then we have these other tests that have been discussed that are not anti-10A tests, like the coagulometry test, which is interesting, but it doesn't tell you what drug the patient is on. So if you think about emergency medicine, a guy shows up unconscious, nobody's there with him. You want to know anticoagulated or not, and with what. A test that can't tell you what drug it is may have some limited capability. So can you walk us through, for the audience, thinking about, based on what folks may have access to, how should what we discuss today impact their decision-making or their practices, or should it?
Yeah, well, no, Arthur, you bring up many, many excellent points, and I don't want to monopolize the next 20 minutes. But when these drugs first came out, right? As you said, Arthur, we were like, oh, wow, these are great. We give them fixed dose. We don't have to monitor. The patients don't have to come to clinic. I mean, they really changed how we practice, right? No Lovenox for PE, DVT, right? No enoxaparin or anything. But then we wanted levels. And so I remember dabigatran was the first on the market, and I told the local community hospital to get a thrombin time, right? But to see where the patient was at. Well, I didn't know it took them 5 days to get that back. That was over, 13 years ago, right? So I think people have to look at their institution, look what's available, and look what the indication is for measuring, right? You can certainly use an anti-10A level for the 10A inhibiting DOACs. You can use either an unfractionated heparin or a low molecular weight heparin curve, right? Because what happens is you do the 10A assay and you get a result, but then it's the nomogram curve that actually tells you what the values are. So I used to love to do this when patients came in on rivaroxaban and needed urgent surgery, or I think we see less of this now, but someone forgot to tell the patient to stop their rivaroxaban before surgery, and they come in and the surgeon wants to know, oh my God, can I do this, moderate to high risk bleeding procedure? And we would send off an anti-10A because we had it available for low molecular weight heparin, and we get values like 7, right? 7.0, when the normal range, for low molecular weight heparin is up to 1.0. So you can certainly use those lab-based tests, even if you don't have a specific apixaban one, for what we were discussing and what Kamran was discussing. Someone comes in, they have major bleeding, you have no idea what's going on with them. You need to know if they have anticoagulation on board. Or they come in and they've had a stroke. They're supposed to be on anticoagulation, but why do they have a stroke? Are their levels too low? So I think that's where it would be nice if we did have a more rapid point of care test available to tell us, first of all, yes or no. I think that's a big question. And we even see this in the wards and in the intensive care units, right? Someone is in for some reason that has nothing to do with anticoagulation. It's just happened to a patient of mine. The anticoagulation is continued, and then they have like some urgent need to go to surgery. And oh my gosh, how are we going to figure out what their degree of anticoagulation is? The surgeon even kind of yelled at the team that, why'd you continue the 5 of apixaban twice a day? I would have put them on Lovenox, right? So again, I think point of care testing, which is what Libby nicely described, which is so rapid and at the bedside, can be used in those urgent and emergent situations. The other situations where you were discussing the tests, Arthur, like sending off to one of our favorite commercial reference labs to see if somebody who weighs, 300 kilos or had gastric bypass, and you kind of want to know they have some drug on board at a peak time. We're not going to talk about levels, but you will get some information out of that. That's a very different situation.
That's absolutely right. And I think that the key takeaway here is making sure that we understand what the test is telling us and what it's not telling us. So in a lot of these settings, we're doing a testing to some of the examples you gave. Is there a chance that the patient walks by a rivaroxaban tablet and absorbs some, right? Is there any drug on board for any reason? That's very different from is the dose right, which the dose is determined by how the studies were done and the patients tolerated for the majority of patients. There are times where it might make sense, but make sure you know that you're asking the right questions, and then make sure you're interpreting the answer right when you do these tests. So I bring this up to say, look, Jean has been involved with this since these drugs hit the market. She's got very advanced lab. She's got very advanced lab practices at her facility because of what she has access to. But that is not necessarily the norm. And so I'll bring back Margaret into this as well in her practice setting to say, kind of driving some of this home with the typical accesses that a site may have, what kinds of questions should they be trying to answer with testing? Like what clinical scenarios would testing potentially make sense? And how would testing if something like what Kamran is using became available in the US, more readily available, a coagulometer that, says, is the patient anticoagulated or not for whatever reason, where might that actually change the practice? Or would it just tighten up what we believe, about the results that we're getting with what we're currently doing? Right? Would it actually have a new place in practice, or would it make us feel more confident with what we're already trying to do? So Jean, Margaret, either one of you, how do you feel about that?
Well, I work at an academic center, so we do have the anti-10A calibrated testing. And of course, the temptation is always to try to interpret a range, but really the times that I recommend using it, and we have it available stat, is the person on anticoagulants or not when they need an urgent surgery, or potentially someone who has impaired kidney function, thought they stopped the medication long enough and is going to go through a very big surgical procedure. Can we be sure that there's no residual anticoagulant effect? That's generally when I utilize it. Now, we also have separate research-oriented studies. So testing the hypothesis that people at the extremes of the ranges, that maybe we could demonstrate some correlation with clinical outcomes. So we do have some studies that showed the older you are, women, for example, or certain characteristics, you're on the standard fixed dose of a DOAC, your range actually quite differs from someone else. So is that something like how kidney impairment affects DOAC effect? But that I would clearly say that's not ready for clinical practice. I would strongly recommend against using that to try to dose adjust or cut the dose or increase the dose to target some range. Right now, we're still in the proof of concept that a particular DOAC level correlates with clinical outcomes. So getting back to your question, Arthur, is personally, I think it is useful to have a way of quickly telling if someone's on actively anticoagulated or not, for purposes like emergent surgery, for purposes like acute bleeding, and should you give a reversal agent. And I don't know the data on how prevalent anti-10A testing is available, on a stat basis in most centers. My guess is not, and that may be where a quick point of care assessment, and even a qualitative one, yes, no threshold of a DOAC may be useful if the cost of the machine, if the cost of all the reagents, maintenance, I guess like updates, computer updates, it justifies how frequently you're going to be used. And that's the part I don't know. So maybe anyone on this talk who's used these machines, how much do they cost? And is it actually used enough to justify that cost?
I'm going to jump in for a second, and because there is a regulatory issue that is unique to the United States compared to Germany. And Kamran, you're using a point of care test in your workflow to determine if people can safely go to thrombectomy, or to determine why they had a stroke if they're supposed to be on anticoagulants. But there is, in the US, there's some anxiety about CLIA licenses, clinical laboratory licenses, and point of care testing. And so everything that Margaret brings up, let's forget about cost for a second and just talk about, who owns the machine in the hospital. How do we make sure that the reagents are, not expired? Who keeps track of that? And how do we make sure that the people using the machine, QCing the machine, are competent in maintaining that? And I think I personally think point of care devices are fantastic. I can tell you my, super duper academic lab, we instituted a Pixban and rivaroxaban testing before they were approved for availability, with 24/7 turnaround time in a half an hour once the sample got to the lab. Still has a problem with point of care testing. And so I think that's a barrier that we need to overcome. I will tell you, the reason we implemented a Pix and Riva testing is because we had participated in the Annexa 4 study and had set up a culture of use for andexanet. And when no matter what the lab cost of that test, when you compare it to 1 or 2 doses of andexanet, you've wiped out any lab costs. But you raise a very valid point, not only about the cost, but also the ownership of point of care devices. But I do think that in many of these situations, the cost of the test and what we charge are 2 different things. But if you're Kamran and you're looking at someone who has an acute thrombotic stroke and you want to do thrombectomy and you want to know if you can do it safely, the cost of the test outweighs, I think, the end result of potentially preventing, bad stroke outcomes. So a lot of cost effectiveness analyses probably need to be done. I think there are just, I'm not sure which point of care device is approved. I think there is one approved, but I'm not sure what the costs are.
I completely agree with Jean. I would say there's just a couple comments. Now we are like in the testing phase, so we are not deciding regarding the results of blood check. We are doing thrombectomy anyway. I mean, the patient's coming, there's an indication for thrombectomy, you're doing the thrombectomy anyway. We're just testing the patient just to understand what is just opening the way for just to understand this patient's coagulation status, why they're getting stroke under DOAC. So just another comment. So how we can decide, for example, to stop the DOAC in these patients prior to surgery? So how many the significant proportion of the patient I do thrombectomy, they have stopped and taking DOAC, for example, for planned any operation. So when is safe to stop? What we are doing like, we have ethical approval for that. We are doing testing like just to know. Most of the time, what we see is that after 2 days, there is no anticoagulation effect of DOAC. So we don't have to wait like 5 or 7 days. So in this 3 or 5 days, patient is completely not anticoagulated. So we tested also the onset of action. So we give, for example, let's say apixaban. When is the onset of action? When comes the effect of the anticoagulation effect? We don't know. So we tested it. We did it in dabigatran, and we have seen in this first 48 hours, more than 80% of the patients, they don't have the dabigatran effect in the like coagulation, not anticoagulated. They're like, I would say we're now in the testing phase. We're trying to understand what's happening because obviously one fixed dose fits all. It doesn't work. It's not this way. So there's a big inter-individual variability in the same medication. So we're trying to understand this stuff. But I would say that most of the time you are not deciding regarding the results of blood check, we are now testing the patients and just to understand the whole stuff and opening ways, like as I say, prospective study. What happens if we do, for example, coming stroke? We're doing the let's say the DOAC test, and we're seeing okay, not anticoagulated, but we give the intravenous thrombolysis. So we can do in the control group, we see the safety endpoint with hemorrhagic, for example, complication. So because they are not doing actually in Europe, and for example, and then also in Switzerland, they're giving TPA despite of the DOAC. So now there are ongoing trials, but they are not testing, they're not knowing. But what they know, DOAC not works. But why not work? So we're trying to understand this stuff. Yeah.
I'm gonna jump in for a second because we're talking about peri-op, not so much stroke, acute stroke, but Jim Ducatus did a fantastic trial that's published in New England Journal called the Pause trial, where they held DOAC for pre-specified times based on renal function and actually demonstrated that the hold times of 48 hours brought people's levels down to a threshold that was safe to do for surgery. So if there's any doubt about these data, take a look at that trial. Again, for 80 to 85% of people taking a DOAC, the dose is sufficient. We don't need to check level, maybe even 90%, and the hold times absolutely work. It's those people that are outliers, like, on dialysis, we see these people, and on apixaban that we may not know how rapidly they're clearing.
So that's a really good point. I think the the beyond the emergency settings like we've referred to and that kind of thing, I think if you were to think about incorporating these tests and doing so thoughtfully, I think it really has to do with what are the populations that we've stretched to, right? So we had questions about use in obesity. That's pretty much been answered, I think, pretty well. But there are some thoughts. Gosh, how many patients with a BMI of 55 were in the clinical trials? Okay, now we're answering a question that maybe hasn't been adequately answered. We're stretching to use an ESRD and dialysis based on some some pharmacologic studies. Okay, it would make sense clinically, but maybe that's a study, maybe that's a population that stretches a little bit of the data. We're extrapolating a bit. These are some places where we need to think about this, but what we need to be very cautious about is just, if you build it, they will come, right? So if you make these tests widely available, they will not only be used more, but they will be misused and they'll be misinterpreted. And I think that using them where they need to be used is absolutely key. I can tell you this, and trying to incorporate these tests locally, what you often deal with is kind of chicken and an egg situation with the lab. You say, hey, lab, I would like to have a apixaban calibrated anti-10As, and they'll look back and they'll go, well, you haven't ordered that very much, and so you must not need it. We go, well, but if I had it, I would order it and I would use it differently. And I think that's absolutely true in trying to get these kind of protocols through. But we have to think about, is that going to impact how we clinically use the test? Because I have access to it, am I now going to stretch and use it in places where perhaps it's going to answer questions that shouldn't have been asked? And so those are kind of the questions. So limiting to the population where we know that it's going to be beneficial, helping us answer questions in emergency settings and those kinds of things, and not stretching beyond where we have good data to suggest we don't need to answer the question.
There's so many questions that we wish we could address in the Q&A.
A lot of questions.
I'm looking at the time, and we are at time. Thank you to all of our presenters and panelists for your insights on this topic. I think, yes, we should do research like Kamran is saying, to say of the people who have bad outcomes, like, can anti-10A testing or DOAC specific testing help guide us? I still think it is an open question, but in certain situations where we want to know whether there's an anticoagulant or not, there are these promising modalities, and I'm very excited to see how this field evolves. So thank you all for joining our webinar, and hope to see you at our next Anticoagulation Forum webinar.